Sir, please start.
Uh, Good evening, everyone. I welcome you all for today's webinar on advances in oncology. With immense pleasure, I would like to invite Dr. Ruchi Shah, who is consultant medical oncology in uh, Apollo Cancer Center, Ahmedabad. The welcome and for the welcome and introductory note. The stage is all yours.
Yeah. Hello, everyone. Good evening. So, welcome you all for this wonderful academic session. And first of all, I would like to thank our sponsors of this today's session, the AstraZeneca, BMS, and Bharat Serum. And I would like to straight away start with our first topic, which would be taken by Dr. Bhushan Dombre. Sir is a senior surgical oncologist, thoracic surgeon at Apollo Hospital, Delhi, and who will be covering management of early carcinoma of lung. So over to you, sir. Uh, Dr. Bhushan, you are on mute probably. Yeah, please unmute yourself. Still not audible, sir.
Sir, please connect your microphone. Otherwise, use your earphone or headphone.
Not audible.
Now can you hear?
Yeah,
Yes, sir.
now we
Sir,
can hear.
please mute another device.
Yeah. Now you can hear clearly.
Yes, sir.
Okay. Let me share the screen.
Sir, please rotate your phone screen on horizontal mode.
Okay. Yes. Yeah. So I will share my screen from. Oh, it's gone. How come it's gone? Wait. Hold on. I think so. Some problem. It's not
Sir,
coming.
you have to share the presentation in Zoom.
Yeah, I know that.
Sir, first of all, open your presentation in background.
Yeah, it's open.
Okay, now come back to in Zoom, sir.
Yeah.
There is a share screen option in bottom, sir.
Yeah,
Green color
that's what.
icon.
Wait. It's going slow here. Yeah. So yeah, I will share the screen from my laptop.
Yes, sir.
Yeah, now it's
Just click on share button, sir.
wait. It's disappearing. It's disappearing. It's gone again.
Also share with me. I will share the slide.
Yeah. This is share screen sharing. Yeah, can you see? Can
No,
you see?
now we can.
No?
Yes, sir.
Huh?
Make it a slideshow
Oh,
mode.
okay.
Okay, perfect, sir. Please continue.
Perfect. Okay. So, greetings from Dr. Bhushan. I'm a thoracic surgeon from Apollo Indraprastha Hospital. I will put a start on the nutshell in the management of early stage lung cancer. Why it has recently got some interest in early stage lung cancer. Previously, it was a surgeon's domain, nowadays we have new modalities coming into this domain. So as you know, now we are following HACC ninth classification. You can see from this early stage lung cancer is refers to stages 1, 2, and 3A, non-small cell lung cancer, as well as limited stage small cell lung cancer. You can see from the diagram that up to 3A, this comprises of the early stage lung cancer. So this is the TNM ninth edition. There are minor differences. So what are the minor differences? No changes to the T component, but subdivision of N2 involvement. They have made it into N2A single station N2 disease and N2B multi-level multi-station N2 disease, and subdivision of metastatic disease into M1C into M1C1 multiple metastasis in a single organ system and M1C2 multiple metastasis in multiple organ systems. So what is the diagnostic workup in any lung cancer? Imaging modalities, PET-CT or coupled PET-CECT, MRI brain. Biopsy can be done by either true-cut biopsies, ultrasound or CT guided, EBUS FNA or US FNA, or mediastinoscopy sometimes used nowadays, and surgical biopsy. When tumor is very close to a vital structure, we are not able to get any biopsy from other modalities. And nowadays we have now after biopsy there are predictive biomarker testing, ALK, ROS, PDL1, and there is some we do sometimes liquid biopsies as well. So, what are the treatment options available in lung cancer? Local treatments comprises of radiation therapy in the form of SBRT radiation and surgery, obviously. And systemic treatments now it has diversified into chemotherapy, targeted therapies, and immunotherapy. What are the treatment options for early stage lung cancer? So surgery, VATS, robotic open surgery, whatever the surgeon is capable of. SBRT, if a tumor nodule is small, you can do SBRT. Neoadjuvant chemotherapy. This was in the previous era, we used to give neoadjuvant chemotherapy. Nowadays, what has changed recently is neoadjuvant chemoimmunotherapy and target therapy. And we are getting data from stage 1B onwards. We can use neoadjuvant chemoimmunotherapy, surgery or radiation followed by neoadjuvant therapies. So every lung cancer has to go through an MDT. It has to be either the patient is of pulmonologist, either the patient is of thoracic surgeon or a medical oncologist or the radiation oncologist. A plan should be drawn depending on the resectability and operability of the patient, even though it is a early stage lung cancer. As you can see, all these people are there involved in the MDT in lung cancer. There is an extended team also involved where a nutrition specialist has a vital role, rehab therapist and nurse. Apart from thoracic surgeon, medical oncologist, and radiation oncologist, what is crucial as a team in lung cancer MDT before deciding on the plan? Assessing the PET-CT and CT scans very carefully for resectability, and nodal evaluation should be done as a part of accurate staging, either EBUS, mediastinoscopy, whatever, and taking account into resectability and operability. So here resectability is a surgeon can achieve R0 resection, nothing less than R0 resection, and operability is gives about the idea about the overall general condition of the patient, whether the patient is clinically fit, medically fit or not, and operable or not. That's what. So what has changed recently is neoadjuvant therapy in non-small cell lung cancer. It is recommended in patients with T3 or T4 tumors, stage 3A, N2 disease, superior sulcus tumors, and all agents are platinum-based doublet plus radiation. As you can see from the diagram, stage 1A and small b surgery alone, stage 2 and non N2 3A surgery plus adjuvant chemo can be given. And neoadjuvant therapy plus surgery is N2 stage 3A disease. Non-small cell immunotherapy area, you can see 1A is surgery. Sometimes the patient is inoperable, like medically unfit. If you can consider SBRT, or if the tumor location is close to the chest wall, you can consider radiofrequency ablation also. And stage 1B, 3A, neoadjuvant plus chemo, plus minus chemo, plus surgery, plus adjuvant IO or targeted therapy or chemo plus radiation. So, what is the impact of immunotherapy in lung cancer? Uh, lung immunotherapy in lung cancer. Chemotherapy, radiation, surgery were the mainstays of treatment. Immunotherapy marked a paradigm shift, offering a more targeted and a potential for long-lasting approach. It has changed dramatically the treatment landscape of lung cancer. I think so. It has the lung cancer treatment has become more and more complicated. As we go through this seminar, we will come to know more and more about it. More interest in neoadjuvant setting in early stage lung cancer because of people want pathological CR. Whether this pathological CR is getting converted into improved survival, the answers are yet to come. And but with neoadjuvant strategies, enhanced tumor shrinkage, improved pathological response, better immune system activation, reduced recurrence risk, and everything may reflect there is a hope for improved survival. Now, as a surgeon, I will come to early stage lung cancer and what are the options available in lung cancer surgery. It is lobectomy, bilobectomy, segmentectomy, very rarely pneumonectomy in early stage, bronchial sleeve resections if the tumor is located at any right upper lobe bronchus or the left upper lobe bronchus. We can do lung preservation surgeries. Double sleeve resection where a bronchial sleeve as a vascular sleeve can be taken, and sometimes very unfit patients, very small GGOs, wedge resections can be done. This is the lung anatomy in short. These are the resections you can see from the highlighted areas. These are the sleeve resections, the diagram where the tumor is located, and the cut, how we can cut and reimplant the bronchus. This is the multi-port VATS, single port VATS, whatever modality. Now, coming to stage one, NCCN guidelines mention node negative nodal status has to be either operable, then surgical resection with mediastinal nodal dissection to be done. Medically inoperable, definitive RT, SABR can be done. This is what again stage 1B operable, medically inoperable. Operable cases obviously surgical resection with lymph node dissection, medically inoperable SABR, and if N1's disease, then definitive chemo radiation. All this evaluation we evaluate for perioperative therapy, PFTs, bronchoscopy, pathological mediastinal lymph node sampling by EBUS, FDG or PET scan or MRI brain. If the tumor is close to the chest wall, T3 invasion and N0, N1, resectable T4, N0 disease, that is exactly the stage 3A disease where it is a locally advanced disease. Surgery is preferred after perioperative systemic therapy is if planned. If margins negative, chemotherapy, and now the immunotherapy role has come. Margins positive, then chemo radiation, sequential or concurrent, or re-resection plus chemotherapy or concurrent chemo radiation. This is another NCCN whole in nutshell. I will go fast. All clinical evaluation is the same. Superior sulcus tumors, if possibly resectable, most of them come as unresectable. Most of them cases go for definitive chemo radiation. If resectable, then surgery plus chemotherapy followed by now immunotherapy, atezolizumab, pembrolizumab, or osimertinib. As unresectable, definitive concurrent chemo radiation. So I can go through few cases. This is a case before the era of immunotherapy. This is a 50-year-old lady, recurrent cough. This is early stage lung cancer. Received neoadjuvant chemoradiation, EBUS negative, uh, and it went multiport VATS. Histopathology showed a residual tumor, nodes negative, received post-operative chemotherapy. And after 5 6 years she survived. She got a brain metastasis, and she is being treated for it. This is another case. This is a 59-year-old lady, chronic smoker, COPD, biopsy prevent 2 centimeter adenocarcinoma in segment S2, right lung, upper lobe. 6 minute POC test was okay, borderline fitness. As you can see, where is the S2 segment? Intraoperative ultrasound was done for localization, and a uniportal robotic S2 segmentectomy with mediastinal nodal dissection was done. And this is the histopathology confirmed 2 centimeter adenocarcinoma, resection margins clear, uh, and she's doing good. So, what evidence do we have? First, early stage lung cancer, especially the stage 1, stage 1B. There's JCOG 0804. Sublobar resection for lung cancer, less than 2 centimeter peripheral located nodules. Lung conservation surgery can be offered. The Checkmate 816, Keynote 671, perioperative immunotherapy role in operable lung cancer. There is this famous Violet trial. Principle of surgery is same. Minimal invasive surgeries have similar oncologic outcomes in with no serious adverse effects, less hospital stay, reduced pain. This is another case of early stage lung cancer with no mediastinal nodes. He was operated upfront, single incision robotic surgery. Since this patient had kidney failure status, we had no option of chemotherapy or immunotherapy. We had to operate this patient. Uh, this is the tumor you can see. Lobectomy was done, and was patient was doing good. Exactly after 4 5 months, this patient had a brain metastasis, and radiation was given. All was attempted, but he couldn't survive. Uh, Coming to another patient who was T2B N0 M0 stage 2A, we operated. And another case is like a 5 centimeter mass in left upper lobe, non FDG mediastinal nodes, EBUS negative. We did a VATS left upper lobectomy. Adding a 5 centimeter node mass, negative margins. It was stage 2 confirmed, and due to size criteria, he underwent adjuvant therapy. This is another case of NSCLC with chest wall invasion. It was a squamous cell carcinoma where we resected upfront the tumor lobe as well as the involving ribs and pleura, and reconstruction was done. He's still alive. This was done 6 years ago. And this is another case, 65 gentlemen upfront inoperable. This is a little bit advanced case. I want to bring this in early lung cancer because he received chemoimmunotherapy, and post IO there was a large cavity in right upper lobe with FDG avid mediastinal nodes. EBUS was negative. The cavity started bleeding. He underwent robotic lobectomy, and histopath found that 1 mm of tumor tissue found. The nodes were negative, margins were clear. Patient was under surveillance 9 months now. Disease is free. He is doing his routine activities. So, what is the optimal approach to lobectomy for a non-small cell lung cancer? You can get a systematic review. There is it is of 88,460 patients. In this meta-analysis supports the role of VATS lobectomy for NSCLC apart from potentially less pain and analgesic requirement with UVATS. Different minimal invasive surgical approaches appear to have similar outcomes. Lobectomy versus segmentectomy. Uh, as well as wedge resections, the pathological stage 1, especially in the elderly population. This is a study. There are feasibility and effectiveness of segmentectomy versus wedge resection for clinical stage 1 NSCLC. Okay, and this is CalGB famous 140503. Has favored segmentectomy for peripheral less than 2 centimeter nodule without mediastinal nodal involvement. Then for GGOs, there are large multi-center trials, whether wedge resection or simple segmentectomy to be done. JCOG 0802 multi-center trial, which is a non-inferiority trial. The segmentectomy is not inferior to lobectomy in small-sized peripheral non-small cell lung cancer. So These are the segmentectomies. Simple segmentectomies in left lung is S1, S2, S3, S4, S5. You can do lingular segmentectomy. Right lung is S1, S6, and moderately difficult are the S2 in the upper lobe, S3 anteriorly, and rest others are within the lung parenchyma are the most difficult segmentectomies. It might be bisegmentectomy, trisegmentectomy. So robotic and VATS. Robotics seems now longer operative time without superior advantages in morbidity rates and oncologic efficacy. Further prospective trials are yet to coming to validate its short-term and long-term efficacy. But future is robotic surgery. Open robotic and thoracoscopic lobectomy portal study. This also mentions like that. So robotic and VATS approaches were associated with favorable perioperative outcomes compared to open lobectomy. Robotic assisted lobectomy was associated with reduced length of stay, decreased conversion rate when compared to VATS. So stage 1 and stage 2 disease generally considered operable and usually resectable. Stage 3A disease may be or have operable resectable disease. Operability and technical resectability should be differentiated on the basis of imaging, pulmonary and cardiac function, and the patient's performance stages. So take home message, early stage lung cancer usually refers to 1, 2, and 3A. Come under generally a front resectable category, but recently it has come under MDT, where a radiation oncologist can also take over, where a medical oncologist also can take over in the form of neoadjuvant therapies, or completely SBRT can be done in stage 1 cancer patients. Thorough mediastinal assessment to be done, lobectomy, segmentectomy, along with mediastinal nodal dissection at present standard of care. Term operability takes into account the resectability, performance status, and tolerance to surgery. Sublobar resection will be the future, both wedge and segmentectomy. Possible resection, resectable, non-resectable at initial can be made resectable by neoadjuvant therapy. Robotic surgery is the way forward. VATS, RATS, and open. That depends on your institution and your surgeon's capability. But it has to be R0 resection, and oncological outcomes should be margins clear. It has and also a safe surgery. Thank you. I would like to share some experiences with post chemoimmunotherapy lung resection challenges. As a surgeon, nowadays immunotherapy has become very much popular among the medical oncologists as well as the lung cancer treatment groups. So, whenever you give the immunotherapy as a new adjuvant treatment modality, you find there are dense adhesions, sometimes flimsy adhesions, and sometimes the bubbles are seen in the pleura. Then there are friable lung, the friable vessels. Sometimes they are very much adherent. The node which has got a good response are densely adherent. It might lead into catastrophic bleeding and injury of the vessels. Lymph nodes stuck to the pulmonary artery. They are plastered on the pulmonary artery. Sometimes a sleeve resection of vessel, double sleeve is required. Sometimes you have frozen hilum. Then mass stapling or mass ligature and suturing is required. Thank you.
Yeah, thank you so much, Dr. Bhushan, for sharing these wonderful insights. No doubts that improvement in the surgical techniques as well as the use of chemoimmunotherapy in this early lung cancer patients have improved the outcome very well. And you quite beautifully shared the insights on how the impact of what is the impact of chemoimmunotherapy on your I mean, at the time of surgery, you are facing such challenges. We all have limited experience, at least I have limited experience of neoadjuvant chemoimmunotherapy because as said, these patients are quite less at the presentation.
Yes. Actually, the immunotherapy will be the way forward, and whatever we are seeing now Everything is going to change every 6 months. So probably, I don't know. Some people will be responding to immunotherapy, some won't, some will be resistant to immunotherapy also. We don't know. So all the three modalities will be have to be present throughout the treatment process of the patient, lung cancer patient.
Yes, well taken. Thank you. Thank you,
Thank
Dr.
you.
Bhushan. Yeah, so moving forwards, we will move to the next session. This session is sponsored by AstraZeneca. And I would like to invite Dr. Rishabh Kothari, who will be talking on trastuzumab deruxtecan for the treatment of hormone-positive HER2-low and hormone-positive HER2-ultra-low metastatic breast cancer. So Dr. Rishabh Kothari is a senior medical oncologist with Oncology. So I would like to hand over to Dr. Rishabh.
Thank you, Dr. Rushit, for invitation. I would be discussing on TDXD in hormone positive HER2 low and HER2 ultra low setting. Largely, I would be discussing uh, Destiny Breast 06. Next slide, please. Next slide. Uh, Next slide. So as we know that a lot of hormone receptor positive patients do have some HER2 expression. Initially, we came to know that HER2 low is a subset where TDXD would help, which made up to 60 to 65% of of the patients. And now we know that even HER2 ultra low would do well, which is IHC 0, but there is some staining less than 10%. So right from IHC 0 to IHC 2 plus IH fish negative, ultra low and low subset do benefit from TDXD. So this will make around 80 to 85% of our patients who are hormone receptor positive. Next slide, please. Yeah, so all of us are aware of this definition. What is HER2 low and what is HER2 ultra low? Next slide, please. 1 plus and 2 plus fish negative is low, while IHC 0 with some membrane staining less than 10% is HER2 ultra low. Next slide, please. So as we are aware that first line endocrine therapy plus CDK4/6 inhibitor is standard of care, and most of the time we would get somewhere around 1.5 to 2 years with this regimen. But then second line onwards, most of the drugs don't work well. So your second line endocrine therapy may give somewhere around 3 to 5 months, and third line chemotherapy generally again addition of 6 months or so. Based on Destiny Breast 04, we know that in such patients in third line or later, we may get PFS of around 10 months. Next slide, please. I think we will skip mechanism of action. All of us are aware of it. So we can skip 2 slides. Next slide. Yeah. Next slide. Oh, this is the previous one. So that this is trial design of Destiny Breast 06. Hormone receptor positive metastatic breast cancer, HER2 low and ultra low as discussed prior. Chemotherapy naive patients who had prior lines of 2 or more endocrine therapy with or without targeted therapy, which would be CDK4/6, or one line of therapy and progressed within 6 months of first line ET plus CDK4/6, or had recurrence on adjuvant endocrine therapy within 2 years. So basically, platinum, if they are hormone refractory or had primary resistance to endocrine therapy, they would be allowed without 2 lines of therapy. If not, we need 2 lines of endocrine therapy, but they all should be chemotherapy new. They were randomized 1:1 to TDXD versus treatment of physician's choice, which is capecitabine, nab-paclitaxel, or paclitaxel, largely acceptable control arm. Endpoints PFS in HER2 low patients. Key secondary endpoints were PFS in intention to treat population, overall survival in HER2 low, overall survival in intention to treat population. And then they have exploratory analysis of HER2 ultra low patients alone. Stratification factors were prior CDK4/6, yes or no, HER2 expression 1 plus versus 2 plus fish negative versus IHC 0, and prior taxane in non-metastatic setting, whether they received or not. Next slide, please. So baseline characteristics, it is well matched across both the arm. Around 15 to 17% patients were HER2 ultra low, and rest of the patients were HER2 low. Next slide, please. Yeah, these patients had a lot of disease burden. If we can see, around 86% patients had visceral diseases. Around 65% patient had liver mets also. And median number of disease sites was 3 across both the arms. Next slide, please. So prior line of endocrine therapy was 2, and generally it was fulvestrant and ET plus minus CDK4/6 inhibitor in most of the patients. Again, these things are well matched across both the arms. Next slide, please. Next slide. So this is the primary endpoint, PFS in HER2 low patients. The median PFS is 13.2 months versus 8.1 months with hazard ratio of 0.62, confidence interval not crossing unity, and a significant p-value of less than 0.001. So this makes not only statistically significant but clinically meaningful improvement in PFS compared to standard of care in HER2 low patients. Next slide, please. This is in intention to treat population. So HER2 low and ultra low both are combined. Again, the quantum of benefit is almost similar, 13.2 months versus 8.1 month. Hazard ratio of 0.64, not crossing unity, and a significant p-value. Next slide, please. So overall survival, it is still not mature. The number of events are low, but in spite of crossover in around 15 to 20% of patient, hazard ratio are 0.83 in HER2 low, and in intention to treat population is 0.81. Both are crossing unity, but hopefully with longer follow-up, we would get some difference. Next slide, please. So this PFS benefit was seen across all stratified risk factors, whether it is IHC 1 plus or 2 plus with FISH negative, previous taxane used or not used, prior CDK4 inhibitor used or not used. Not used patients were very few and events were very low, whether it was primary resistance or secondary resistance, and whether it was compared with paclitaxel or capecitabine. Next slide, please. So all the forest plot was favoring TDXD. Again, response rate, if we see, it is 56.5% versus 32.2% in HER2 low population. And in HER2 ultra low, it is 61.8 versus 26.3%. PFS by time to progression to first line endocrine therapy and endocrine resistance. So irrespective of less than 6 months, 6 to 12 months, or more than 12 months of progression on first line therapy, TDXD had improvement in PFS, and delta was 7.5 months for resistant population. For 6 to 12 months patient, it was delta was 6.3 months, and if it was sensitive population, it was 4.7 months. All statistically significant with hazard ratio ranging from 0.38 to 0.69. So irrespective of endocrine resistance, whether it is primary or secondary, TDXD had benefit in PF in terms of PFS over physician's choice of treatment. Next slide, please. So PFS2 also was better with TDXD arm. Median PFS2 was 20.3 months versus 14.7 months with hazard ratio of 0.62. Again, this was irrespective of primary resistance or secondary resistance. And this is one amongst the other reason to say that probably we will get overall survival benefit also in longer term because PFS2 is also longer. Next slide, please. Irrespective of disease burden, whether it was high burden disease or low burden disease, TDXD had improvement over treatment of physician's choice. If it was less than 3 local or metastatic site, the delta was 6.9 months. And if it was more than equal to 3 months, it was 3 sites, it was 4.2 months. Next slide, please. Next slide. So once we are aware of efficacy data, the next important thing is what is the safety of this drug. This is a newer molecule, reasonably newer molecule. So we must be aware how to manage the toxicity and what to expect with this drug. So any adverse event were almost there in both the arms in almost all the patients, 98.8 versus 95.2%. Important grade 3 or higher toxicities was 40.6 versus 31.4%. Serious adverse event 10.6 versus 5.8%, leading to dose reduction or dose interruptions. It was uh, almost similar, more than 60% in both the arms. Death related to largely treatment, it was 2.5 versus 1.4%. So it looks like there is some increased toxicity with TDXD compared to physician's choice of arm. And because efficacy is so great, we need to learn how to manage this toxicity. Next slide, please. Next slide, please. The previous one. So what are the important toxicities which we should be aware of? So nausea, vomiting is common. TDXD is high hematogenic drug. So we need to be very careful of antiemetics we are giving. Fatigue, alopecia, cytopenia, transaminitis are other problems which we need to be careful of. Next slide, please. And some unusual toxicity which we expect from TDXD, which are not routine with chemotherapy. Next slide, please. Are interstitial lung disease and uh, decrease in ejection fraction or cardiac failure. So interstitial lung disease is seen in around 11.3% of the patients, of which grade 3 or higher is seen in around 1.5% of the patients. So this we need to be careful of. We need to monitor because anything beyond grade 3 can compromise patients' quality of life. Ejection fraction, we are used to monitor this and manage this in all HER2 directed therapies. So that probably we all are aware of. Next slide, please. Next slide. So quality of life, again, there was no detriment in quality of life and time required to uh, reach to better quality of life compared to chemotherapy in TDXD arm. Next slide, please. So largely it maintained overall quality of life. Conclusion, TDXD in HER2 low population has shown improvement in PFS and it has shown also in intention to treat population. So largely HER2 ultra low population also mirrors the benefit of HER2 low population. There is better overall response rate, better progression-free survival uh, with some increase in toxicity and comparable quality of life. So this makes it is an effective new treatment for patients with hormone receptor positive, HER2 low and ultra low metastatic breast cancer after more than one endocrine therapy. So before receiving any chemotherapy, TDXD would be an appropriate option for this subset. Next slide, please. Next slide. So I think we have discussed antiemetic part. This is the antiemetic part that we need to treat as high hematogenic chemotherapy. So we need 3 drugs. Next slide, please. For prevention of nausea, vomiting. This is same 3 versus 2 drug. 3 drug is recommended. Next slide, please. ILD, as we discussed, we need to be careful of, watchful for of symptoms, and if there is small symptom, we need to do HRCT and confirm whether ILD is there or not, and try to pick it up in grade 1 or grade 2 rather than once it is grade 3 or more. Next slide, please. This is management of grade wise toxicity that we all are aware of. Next slide, please. Next slide. Next slide. Yeah, next slide. So this has been now incorporated in both the guidelines, the ESMO living guidelines and even the newer NCCN version. So next slide, please. This is something which we already discussed that, yeah, so this is ESMO living guidelines, which have accepted as first line of treatment when you need other than endocrine systemic therapy. Next slide, please. Yeah, and this is also captured in NCCN. Next slide, please. Yeah, thank you.
Thank you so much, Rishabh Bhai, for this wonderful presentation. Yeah, I mean, day by day, we are learning to work with these ADCs, especially trastuzumab deruxtecan, which is the most recent one of the wonder drugs. Practically, how many percentage of patient you see pneumonitis, Rishabh Bhai?
So to quantify in percentage, we need to give to 20 patients, which I have not done.
Yeah, yeah, exactly. Same
I
for
think
me.
AstraZeneca would be in a better position to tell. But as we can see that from our initial Destiny trials, the chances of ILD was very high initially, but then even in trials, people have learned how to manage it and how to document it. In my routine practice, I generally do a HRCT after 2 cycles, not to see the response, but to see whether ILD is there or not. And if there is some suspicion of increased cough or breathlessness, threshold to do HRCT is very low.
Yes, you are right. So whenever we are detecting it early, we can stop early, and that may be a chance of re-challenge later on. So data is coming for that also.
At least we will not deteriorate their quality of life. Even if we don't re-challenge, at least the toxicity is not much that it will hamper their routine life. If it is grade 3 or higher, sometimes even if disease is under response, they will continue to be
Right.
symptomatic because of the lung.
Right. So for that part, we are little skeptical on especially the elderly patients. So yes, that things needs to be done. And as you rightly said, the monitoring, close monitoring with CT scan will really help. Thank you. So
Thank you.
now we are moving on to the next session. So this session, the next two sessions again are sponsored by AstraZeneca. So now I would like to invite Dr. Kaushal Patel. So he will be talking on treatment dilemma regarding monotherapy versus combination therapy in metastatic EGFR mutated non-small cell lung cancer. So Kaushal Bhai is a senior medical oncologist working at Surat, and over to him, Kaushal Bhai.
Yeah, thanks, Rushit. Thanks, AstraZeneca, for giving me the opportunity to speak on this topic. Now in 2025, we are making things little complicated rather than making simple. So initially, we have options of the treatments in each for positive malignancy, starting from the Japanese to many other available options of the treatments. Now we are moving little one step ahead, and that is the combinations of the therapy rather than single agent TKI. Yeah, hopefully my slides are visible.
Yes, they are.
Yeah, thank you. And these are my disclaimers. The slides has been provided by AstraZeneca. Little modification has been done with the permission from the company. And these are the points to be discussed in our today's discussion. So now we are starting with the EGFR mutations positive non-small cell malignancy. And if we see, then EGFR has been mutated in approximately 40% of the Asian and 20% of the non-Asian populations. Incidence rate of the EGFR mutations among the Indian populations is roughly approximately same as Asian. It's around 40%. And EGFR mutations, they are located in tyrosine kinase domain and result in increase into the kinase activity of the EGFR, leading to the continuation cell proliferations. The most common EGFR mutations, they are deletion in exon 19 and exon 21 L8 58R point mutations. So these are the things which is common in our practice. We started with the Japtinib and ended with the osimertinib. So if you see the median PFS in this clinical study, then Japtinib is approximately 9.5 months, and then gradually it is increasing in its double in patients with the osimertinib, that is 18.9. Still, it is not enough in today's era. We want to achieve something more with anything which can be possible in this subgroup of the population who are having EGFR positive. So what is the concept of combining with the chemotherapy? So if we combine cytotoxic chemotherapy with EGFR TKI, then it acts synergically by inducing the apoptosis and suppressing the AKT and extracellular signal regulated kinase phosphorylations, which may delay the resistance to the TKI. As well as to a certain extent, we have impact of the chemotherapy over this subgroup of the populations by the pemetrexed. These are the supportive evidence which has shown that by combinations of the TKI with the chemotherapy, has shown a benefit and overall response rate PFS as well as OS. Initially, it has started with the paclitaxel and carboplatin, which has combined with darotinib, Japtinib, and later on pemetrexed plus carboplatin plus Japtinib. And it has shown a significant advantage in response, survival, as well as PFS. If we see the FLORA-2 study, that's the osimertinib compared with the osimertinib plus chemotherapy. And in this group of the populations, EGFR people has been divided in 1:1 ratio with osimertinib plus pemetrexed plus carboplatin or cisplatin 4 cycles, followed by the maintenance osimertinib and pemetrexed, which has compared with the osimertinib once a day single agent. And primary endpoint of this study was PFS by investigator of the choice, as well as secondary endpoints. There are multiple good secondary endpoints out there, which is helpful in deciding the treatment aspect in our clinical practice in today's era. This is the baseline characteristic, which is matching almost similar in two group of the population. And here there are two important points. That's EGFR mutations, exon 19 and exon 21. They are more or less same in each group of the studies. More of the patients, they are exon 19. Approximately 60% of the patients. And here, if we see approximately 40% of the patients, they are having CNS metastasis, which has controlled disease, or BH, which has been treated with the something treatments. So good number of the patient has been included with the brain metastasis in these patients in studies. If we see the PFS, then there is a significant advantage of the PFS with combination therapy compared to the only osimertinib single agent. And if we see the progression at compared to 60% of the patient osimertinib. If we BIC is also better in patient who has been a combination therapy, approximately 9.5 months of the difference has been documented in this particular. Into the subgroup analysis, then almost all group of the populations, they are getting advantage with the combination therapy of the osimertinib plus chemotherapy compared to the osimertinib single agent. And it has been maintained irrespective of the EGFR type, whether it's exon 19 or exon 21, or irrespective of the brain metastasis and on. Here, this is a very good slide. The patient with brain and without brain metastasis. If we see the PFS advantage, it is more pronounced into the patient who has been CNS metastasis, and approximately 24.9 months of the PFS compared to the 13.8 months, which is almost near about double in patient who has been treated with the combination therapy compared to the single agent osimertinib. If we see the PFS according to the EGFR mutations, then yes, it is almost equally significantly different in exon 19 and exon 21 mutations with the combination chemotherapy compared to the single agent osimertinib. And if we see the second interim analysis, that's overall survival rate, that is better into the patient who has been treated with the osimertinib plus chemotherapy compared to the osimertinib monotherapy. And if we see at the end of the 3 years, approximately 65% of the patients survive compared to the 50% of the patients in single agent groups. And if we see the acquired resistant mechanism, then there is a if we see the FLORA-2 study, then the treatments with the combination did not affect the resistance mechanism and it remained similar across two FLORA as well as FLORA-2. But chances of the resistance with the osimertinib when we combine with the chemotherapy like pemetrexed and carboplatin, it's less compared to the patient who has been treated with the single agent therapy. If we see the safety summary, then no doubt by additions of the chemotherapy, we are increasing the adverse drug reactions due to chemotherapy. And so it is a more pronounced with the patient who has been treated with the chemotherapy combination. Higher grade side effects, they are also common into the patient who has been treated with the chemotherapy. Side effects which lead to the discontinuation of the treatments as well as grade 3, grade 4, and grade 5, which considered as a serious adverse drug reaction. They are more into the patient who has been treated with the combination therapy. And in summarizing, we can say that the grade 3 or more event was 64% in combination arm and it is 48% discontinuation. Mostly it is attributed to the chemotherapy compared to the osimertinib therapy. And these are the side effects which has been in the patient who has been treated with combination therapy. So the chemotherapy induced side effects like pancytopenia, loose motion, mucositis, decrease in the appetite patient therapy compared to the osimertinib, which has been more with the rashes, mucositis, and diarrhea. So we can say that in osimertinib plus chemotherapy, most common adverse reactions they are the hematological and they are known to be associated with the chemotherapy. There were no common adverse therapy, and they are more to be considered with the rather than anything else. A good number of the trials in the Chinese data only from the data and on the FLORA-2, and it all shows that the chemotherapy into side effects they are the higher into the patient who has been treated with the combination compared to the only chemotherapy TKI. So definitely we are achieving something, but we are having some sort of the side effects in chemotherapy. So here the comparison between monotherapy and combination therapy with the different treatments are. And if we see the FLORA-2 study, it shows there is a significant improvement into the PFS in all comers. The PFS advantage is also pronounced into the patient who are having CNS metastases. No doubt the side effects they are common into the patient who has been treated with the chemotherapy plus osimertinib because chemotherapy related side effects they are the common in this group of the populations. And irrespective of the EGFR mutation, whether it's a L858R or exon 19 mutations, the result of the combination therapy in form of the PFS as well as OS has been continuation pronounced. So these are the three which has to be in guidelines in 2025. The osimertinib or osimertinib plus chemotherapy combination and amivantamine plus lazertinib is first-line treatment option in EGFR mutations, non-small cell lung malignancy in advanced stage. And as depends upon the response as well as the result and on progression of the disease, we can use the second-line treatment options, whether it's amivantamine plus lazertinib, ADC, chemotherapy combination, chemotherapy plus amivantamine combination. So depends upon first line treatments option, we can use the second line and beyond second line treatments, whatever left out with us. This is a very good thing in future. With ctDNA monitoring, we can choose the further treatment aspect in future. The osimertinib should be given for the 3 weeks. Then we should do the ctDNA. If it is positive, then we go with the chemotherapy plus osimertinib. Or if the patient is having ctDNA negative, then we can go with the osimertinib single agent. So this study will answer will the high patients with the high tumor burden will benefit more with the combination therapy, or we should continue with the osimertinib single agent. Easier to choose the patient who will have the maximum benefit with the combination therapy rather than giving the only toxicity in this particular subset of the populations. So I summarize my talk. The osimertinib in combination with the pemetrexed has demonstrated a statistical significant and clinical meaningful improvement in PFS compared to the osimertinib monotherapy in patients with the EGFR mutation non-small cell lung malignancy in advanced stage. The PFS in all group they are having significantly better compared to the PFS in osimertinib single agent. Additional benefit in the patients with the CNS metastasis and with L858R mutation has been also documented in form of the PFS. The safety profile were as expected for the each treatments and were manageable with the standard medical practice. The frequency and severity of the adverse reactions, they are the more into the patient who has been treated with the combination therapy. And more or less, these are due to the chemotherapy part rather than osimertinib part, but can be manageable with routine practice and routine medical management. So I end my talk here. I thanks my audience for the patient hearing, and I hand over the session for further questions. Thank you.
Thank you so much, Kaushal Bhai, for this beautiful insight. And I would just like to ask you a question that whenever we are using this chemo plus osimertinib combination, are you able to continue pemetrexed for a long duration with osimertinib, or are you continuing routinely?
Yes. So in my practice, I send the genetic mutations on day one, and if I find EGFR single mutations, then I would like to go with the osimertinib rather than chemotherapy combination therapy. But if I find any other mutations coexisting with the EGFR like P53 or something, non-targetable mutations likely PIK3CA or P53, which increase the resistance or which compromise the effect of the osimertinib, I would like to combine osimertinib plus chemotherapy combination. And yes, I am very much comfortable with the continuations of the osimertinib plus pemetrexed as a maintenance therapy for long duration of the time. Most of the patients, they are tolerating the drugs well rather than having any major toxicity.
Okay, okay, well taken. All right, so now we are moving on to the next session. I would like to invite our next speaker, Dr. Ashish Kaushal. So, sir is a senior medical oncologist based in Ahmedabad, and he'll be talking upon integrating immunotherapy into small cell lung cancer limited stage into the management. So, over to you, sir.
Thank you, Rishit, and thanks for AstraZeneca for inviting. And this is the sponsored session. I hope my screens are visible.
Yes, sir.
So this is a very interesting topic because in small cell lung cancer, we have a very limited options in the treatment. And since many decades, we have a limited treatment protocols. Mainly, we are using platinum etoposide for this subset of the patients. And since more than 2 decades, this is the standard of care. Along with the radiation, we are using for limited stage. And in metastatic stage, we already shown the benefit of addition of immunotherapy with chemotherapy. And we have a overall survival advantage with the 2 oncology agents, pertuzumab and durvalumab, both is approved in metastatic setting. Coming to the limited stage, now there is a new treatment options as we have in metastatic immunotherapy now. The limited stage, the immunotherapy shows the advantage, and which is going to be discussed. But before, we're going to show some of the important data about the small cell lung cancer. As we all know, the lung cancer is one of the common cancer in the world. And in our country, this is also one of the leading cause of the cancer-related death. And it is approximately 15% of all the cancer-related death related to the lung cancer. As we all know, out of all lung cancer, non-small cell lung cancer contribute to approximately 85% of the patient, while 15 to 16% of the patient having small cell lung cancer. This is the cancer which usually present in a quite advanced stage. More than 50% of patients are presented in the advanced stage. Only 1/3 of the patients are actually presented in the limited stage. And that incidence varies from region to region. In our country, approximately 25% patients are presented in the limited stage, majority of the patient at advanced stage. Around 50% of the patient they actually diagnosed with the brain metastasis. And the median age of this cancer is approximately 16 years, 60 years. And this is majority of the patients are smokers. So I would say 90% plus patients actually may have history of smoking, especially for the small cell lung cancer. We have Indian data of North India, and that data shows around 27% of the patient actually wish come with the limited stage, and around 73-74% of the patient actually they have in advanced stage. Here we need to treat it with the systemic therapy. And coming to the age group, as I mentioned, 60 years, here it is 57 years, around 80% patient have smokers. The patient having a good performance status, that is COX 0 and 1 is around 2/3 of the patients. Unfortunately, in our country, the delay in the referral in 1/3 of the patients. And because of that, a lot of patients, they receive only chemotherapy, even in this limited stage. And the standard of care, which is chemoradiation, the data shows it's around 1/4 of the patients they receive the standard of care in majority of the centers. Unfortunately, and in our country, very limited patients are candidates for the surgery, and maybe because of the advanced stage of the diagnosis or the late diagnosis of this cancer. And the median OS of this data is around 191 days. So that's approximately around 6 to 7 months on. So there is unmet need in the treatment of small cell lung cancer, especially for limited stage. Currently, with all the available treatment, whether we give only chemotherapy or the chemoradiation, the median OS ranges from 25 to 32 months. And even in those patients with a limited stage, the overall cure is relatively very, very low. We all know the small cell lung cancer is a chemosensitive disease, but even with the chemotherapy and radiation, majority of the patients relapse within short period of time after completion of the treatment. And if you see the data as far as the limited stage, the 5-year OS ranges from 16 to 34%. It's only part of the patient we can achieve that. So there is unmet need to improve the survival of limited stage. A lot of patients, they have in the recurrence in the thoracic region, and that is around more than 50% patient after 2 years, and around 20% of the patients, they have recurrence in the CNS, which will survive with chemo. Small cell lung cancer is a little different staging compared to the TNM. So here it's PLSG staging system is where they stratify the small cell lung cancer, the limited and extensive stage. We all know the limited stage is the disease where the disease is confined to the hemothorax, and that is targeted by the radiation field with or without lymph node perfusion. While in extensive stage where the patient is not a candidate for radiation and the patient having a beyond the limited stage disease. And unfortunately, this is the patient population we see in our practice, majority of the patients. If we talk about the standard care, we all know limited stage radiation and chemotherapy in majority of the patients. Surgery is only limited stage. And few patients we can see in our practice where the patient have this, I would say stage 1 or limited stage T1, where patient underwent surgery and then treated with the chemotherapy and chemoradiation in an adjuvant setting. But majority of the patients are being treated with the extensive stage treated with the systemic therapy, either chemotherapy or chemotherapy. And of course, there is a role of PCI in small cell lung cancer, and there is a more benefit for limited stage, and it is already for even a advanced stage where the patient got a very good response. We talk about the current treatment approach, the concurrent chemoradiation with the cisplatin and rituximab, and the radiation is the standard of care for patient having the good performance status. Some of the patient, they have a poor performance at the beginning, and we treat with a sequential approach where we need to give the chemotherapy to improve the performance status, and then we add the radiation after 1 or 2 cycles of the chemotherapy. But whenever it's feasible, we give the combination of the chemotherapy at the beginning. And the surgery is basically for those patients where we clear the candidate for, and unfortunately, very limited patients are diagnosed. In that stage, we can offer the surgery in small cell lung cancer. And of course, after surgery, the adjuvant treatment would be chemotherapy or chemoradiation if the patient are fit enough and can tolerate this treatment. Unlike the non-small cell lung cancers, there is no approved targeted therapy for small lung cancer limited stage. And before this data, I think there is no immunotherapy can approved with chemotherapy in the limited stage. We talk about the chemotherapy regimen and limited stage, and majority of the patients have been treated with the platinum etoposide, and we preferably give cisplatin along with the radiation. Usually, we give 4 cycles of the chemotherapy, and radiation usually started in cycle 1 and 2. The standard doses of cisplatin etoposide based on the type of practice, but usually we give it even to day 3. And the carboplatin is only permitted if the patient cannot be candidate for cisplatin because of the contraindications. The recommended radiation is basically twice daily in 30 fractions, 45 gray. But in practice, majority of the center, they give the radiation is the once daily because we believe it is more tolerable and logistically better compared to the twice daily setting. And of course, the dose and the vaccination varies from center to center and country to country. But the nutshell is the concurrent chemoradiation is preferred over the sequential therapy. And sequential is basically considered for those patients where the performance is poor, comorbidity, and the patient having high tumor burden cannot be candidated for upfront chemoradiation. There's a role of PCI in limited stage because more than 50% patient having the brain metastasis risk, which can reduce by doing the PCI. And this is recommended for those patients who's having the good response after the treatment, having a good performance, and age less than 60 years for the US patient and less than 74 year patients. The use depends on the clinical factors, patient preference, and the possible risk of neurotoxicity when we give this treatment. And the study shows the benefit as much as 5.4% in terms of OS 3 year, and it reduces the brain metastasis by 50%. There are also options of surveillance with MRI versus PCI is under study for better brain metastasis monitoring. And for that, we need to require more randomized studies and maybe the longer follow-up. Coming to the immunotherapy, small cell lung cancer, we have already approved immunotherapy for extensive stage small cell lung cancer. We have 2 caption and empower studies where the atezolizumab and nivolumab has been approved with platinum etoposide. And those patients having a response, they've been given an option of continuing immunotherapy till progression. And once the patient having progression, the patient is eligible for the second-line therapy based on the response to the first-line therapy. And as for the NCCN guidelines, if there is a recurrence within 6 months, it considers a resistant disease, while the ESMO guideline says 3 months at a criteria. If there is more than 3 months, it considers sensitive. And we can do the re-challenge if there is a sensitive line, but if there is a recurrence or progression, and within a short period of time, we need to give the second-line agents. And out of second-line agents, the option can be either chemotherapy, immunotherapy is not given in the first line, topotecan, annuitican, a lot of other options are there, but all are going to give a very short benefit response. So there is a need of more efficacious and more durable treatment in the first line so that the patient get the best outcome. Coming to the nivolumab in the limited stage small cell lung cancer. So we have a phase 3 randomized double-blind placebo-controlled multi-center study, and that study is called Adriatic study. And this is a study of small cell lung cancer patient, and these are the limited stage patient. And even those patients are stage 1 and 2, which are inoperable, are included in the study, having the good performance status. And these are the patients who treated with the chemoradiation. And the patient who has responded after this therapy has been included, whether it is a response or a stable disease. The PCI is permitted before the randomization. And this is a very large study where the 730 patients have been randomized into the 3 arms. The arm 1 is nivolumab every 4 weekly, around 264 patients included for this arm. The other arm is the placebo of 266 patients, and the third arm is durva plus tremi, around 200 patients have been considered for this arm. For the chemotherapy in this study, they have included 4 cycles of platinum etoposide and patient should repeat at least 3. The radiation ranges from 60 to 66 gray over the 6 week or 45 gray VD for 3 weeks. Radiation must commence or no later than the end of the second cycle. The patient is stratified based on the stage 1, 2 versus 3, and whether the patient has received PCI or not. The treatment has been continued until the investigator determined progression or toxicity or a maximum period of 24 months. There's a dual primary endpoints, durvalumab versus placebo, the OS and PFS. And the secondary endpoint is durvalumab versus placebo, OS and PFS. And other points are the safety and the OS PFS landmarks for both the patient characteristics for this study. Median age of the patient is around 62 years. Around 2/3 of the patients are male patients. 50% patient have the good performer status. And around 2/3 of the patient actually they are the former smokers. And out of stage 1, 2, and 3, around 87% patients are stage 3 patients. Majority of the patients receive the cisplatin etoposide as a chemo partner. And the patient who included both the studies, majority of the patients achieve actually partial response, that is around 70 to 75%. The PCI data, PCI has been given around 53 to 54% of the patients in both arms, and which we are talking about the durvalumab placebo. So this characteristics match in both the groups, placebo and durvalumab, and majority of the patients receive the cisplatin and they give the once daily radiation schedule. The OS data for ADRATIC study with a median duration of follow-up of 37.2 months. So there is a 3-year OS is 56.5 versus 47.6%, favoring the durvalumab over the placebo, and the median OS, which was achieved with the placebo, is 33.4 months. For addition of the durvalumab, it is an improvement of more than 20 months. So the median OS is 55.9 months. So HR is 0.73 and the p-value is 0.0104. So durvalumab is the first and only immunotherapy agents which showed a significant improvement in OS in limited stage small cell lung cancer patient with a median OS of approximately 56 months and the 3-year OS rate is around 56.5%. So none of the oncology drug other than durvalumab has been showed this kind of benefit. That's definitely a very significant advantage in the treatment of chemoradiation, and addition of durvalumab showed a significant benefit. And this benefit is consistent across all the subgroup, whether it is age, race, sex, performance status, whether patients receive PCI or not, and the patient having the radiation schedule once daily versus twice daily, or even the chemotherapy regimen, whether the patient giving platinum, cisplatin, or etoposide, or carboplatin etoposide. So all the subgroup favors the durvalumab. Similar to this, the PFS is also improved with durvalumab. The median PFS 16.6 versus 9.2 months with the placebo, and the 2-year PFS 46.2 versus 34.2%. And there's a significant improvement in the PFS of patient treated with durvalumab in limited small cell lung cancer. Similar to this, all the subgroup showed a significant benefit in the PFS, favors the durvalumab benefits. We are all using PCI in our practice based on the trials, but these are some small studies, and still the real benefit of the PCI versus close surveillance in MRI. I think the studies are going on, and we have to really, we don't know the real answer, but I think we need a randomized studies to get a better meta-analysis to show a real benefit, because there are some disadvantage of using the PCI, especially for the CNS toxicity. But currently in our practice, majority of the patients are prefer taking the radiation rather than going for a MRI surveillance. But in some patients, definitely we can give this option. So in this study, both the patient has been included because the benefit of PCI and limit is still not clear, and we have to do some more randomized trials to get the real answer of treating versus close surveillance with MRI. So in adjunctive study, the patient who receive PCI versus those who don't receive the PCI has been shown an improvement in the outcome. So those patients who receive a PCI, the 3-year OS is 62.1 versus 56.5, the HR is 0.75. While those patients who not receive PCI, it's 50.37 and the HR is 0.7. So OS survival data is better for the patient who received durvalumab than placebo, irrespective of whether the patient received PCI. Similar to the PFS for those patients who receive PCI or not, it's 0.73 versus 0.8. So whether the patient having PCI given or not, the addition of the durvalumab is showing the benefit in terms of the PFS as well as the OS. So this is one of the new data for pattern of the disease progression. We see a lot of patients having limited stage in a short period of time. They have been progression if we treated with only chemoradiation. But if you see the more detail for the type of progression, majority of the patient they actually are having the progression is basically for intrathoracic versus extrathoracic. So the intrathoracic progression is around 28% in durvalumab, while in placebo it is 29.7, and extrathoracic is 18 versus 25. And the new extrathoracic lesion at first progression, you can see the number of the new lesions. If one is in 18.9 versus 28.7, favoring the durvalumab, and the death with those patients, the kind of the progression, you can see the time to brain and see the progression of that. Is the graph is showing the 2 years at 84 versus 72.9. So favoring the more response of the durvalumab, and there is a less time to brain or CNS progression of that with the durvalumab, and time to first progression of that by location. So time to intrathecal progression is less with durvalumab, you can see, and the time to extrathecal progression is that is less with the durvalumab. So more time is going to be required for this progression. At 2 years for time to extrathecal progression of that is 70.9 versus 56.5%. So addition of the durvalumab not only give the OS benefit, PFS benefits, at the same time it's give the more benefit in terms of the CNS progression or type of the progression, or whether it is intrathoracic extrathecal, so all is more prolonged by addition of the durvalumab. And I think this is the agent which shows real benefit in, because none of the agents in last 2 to 3 decades is showing a benefit over the standard chemoradiation, and this is kind of the more kind of consolidation therapy once the patient has been completed with chemoradiation. In terms of the toxicity, none of the arm shows a very difference in the toxicity. You can see the addition of the durvalumab shows minor effects. As we all know, there is hypothyroidism there is some minor pruritus. So minimal addition of the toxicities. There is no new safety signals, because we all are using immunotherapy, especially durvalumab for metastatic setting for limited stage. And the major concern of radiation immunitis, but in both the arm, it is almost similar, 22.9 in the durvalumab arm versus 23.4%. So that is because the radiation has already been completed and the patient is given the consolidation drug. So this edit study, what we can conclude, that durvalumab is first and only approved oncology agent which shows significant improvement of OS and PFS in limited stage small cell lung cancer. As we all know, the limited stage, the treatment is given executive intent. Despite the high response rate, some of the patients they relapse very short period of time, and the long-term outcome is relatively poor. So addition of the durvalumab gives a more meaningful, durable, and quality of life for this patient. Concurrent chemoradiation is standard of care, but consolidation with durvalumab is gives significant improvement and meaningful improvement in quality of life, OS and PFS. Compared to the placebo, the median OS is 55.9 versus 33.4 months. So it is around 22 months, 22.5 months improvement in the OS. PFS also 9.2 versus 16.6. And this regimen is very well tolerated. The data shares up to 2 years, and the safety signals is relatively good, and there is no new safety signal being reported. And based on this data, Durvalumab is approved across the limited as well as now this is a consolidation stage. Durvalumab is already been approved for metastatic setting, and even with the in a non-small cell lung cancer patient, this post-chemo radiations. Here it is in a small cell lung cancer, it shows a significant improvement, and it is approved both limited and extensive stage of small cell lung cancer. With this, I thanks to all the audience and over to the organizers, over to the mission. Thank you.
Thank you so much, sir, for extensively covering this practice-changing trial. So now we are moving on to our last session, and this is the session again sponsored by BMS. So this is a panel discussion. So I would like to invite Dr. Akash Tiwari, who is going to also thank the sponsors and organizers of this event, being AstraZeneca, BMS, and Bharat Serum. Sorry, I think I was not audible.
Yeah, you were muted.
Yeah. Thank you so much, the Dr. Akash Tiwari, for great moderation and in detail discussion regarding this dual IO. And I would also like to thank all the panelists, Dr. Naush Bhai, Dr. Ashish Agrawal, and Dr. Sharad. And yes, at the same time, I would like to also thank the organizers and sponsors, being AstraZeneca, BMS, and Bharat Serum. And thank you all attendees. I'm handing over my mic to organizers.
Thank you everyone for wonderful talk. Technical team, please close the meeting. Good night, everyone.
Good night.